Welcome to the story of renal tubular acidosis, from basics to clinical application by Ahmed S.A. Solomon. This presentation will guide you through the essentials of renal tubular acidosis, from foundational concepts to practical clinical applications. Our contents include 1. Physiology 2, Pathophysiology 3, Classification 4, Diagnostics, and 5. Therapeutics. Each section is designed to build your understanding of renal tubular acidosis comprehensively. The timeline of renal tubular acidosis, RTA, begins in 1931 with Albright's description. Key milestones include the discovery of different RTA types, genetic linkages, and advances in molecular biology and genetic testing. Section 1. Physiology. Understanding the physiological processes is crucial for grasping how renal tubular acidosis affects the body. Let's explore the mechanisms involved in normal renal function. Proximal tubules play a key role in HCO3 absorption. The sodium-hydrogen exchanger, NHE3, and carbonic anhydrase facilitate the conversion of carbonic acid, crucial for maintaining acid-base balance. In the distal tubules, H+ secretion and HCO3 absorption are regulated by aldosterone. The epithelial sodium channel, ENSC, and chloride bicarbonate exchanger, AE1, are vital for this process. Section 2. Pathophysiology. We delve into the disruptions in normal physiology that lead to renal tubular acidosis, focusing on both proximal and distal tubular dysfunctions. Proximal renal tubular acidosis involves mutations affecting the sodium-hydrogen exchanger, NHE3, and sodium bicarbonate cotransporter, NBC1. These lead to generalized or isolated tubular dysfunctions. Distal renal tubular acidosis is characterized by loss of function in the H+ ATPase pump and anion exchanger 1, AE1. Acquired causes include medications and autoimmune disorders. Type IV renal tubular acidosis involves aldosterone deficiency or resistance, affecting the epithelial sodium channel, ENSC. This can result from genetic mutations or acquired conditions. Chronic metabolic acidosis impacts bone resorption, growth, muscle wasting, cognitive development, and immunity. Understanding these effects is crucial for managing long-term outcomes. Section 3. Classification. Renal tubular acidosis is classified into types based on the location and nature of the tubular defect, including distal, proximal, and hyperkalemic forms. Types of renal tubular acidosis include type 1 distal, type 2 proximal, and type 4 hyperkalemic. Each type has distinct genetic and acquired causes affecting acid-base balance. Section 4. Diagnostics. Accurate diagnosis of RTA involves assessing plasma and urine parameters, identifying associated defects, and considering genetic testing for underlying causes. The diagnostic approach includes determining the plasma anion gap and potassium levels, estimating urine pH, and identifying associated defects. Genetic tests may be necessary for secondary causes. Data gathering involves a focused history and examination to identify symptoms and signs of RTA. Key laboratory tests include plasma anion gap and potassium measurements. Urine pH, anion gap, and osmolar gap are critical in diagnosing RTA. These parameters help differentiate between types and identify the presence of tubular acidification defects. Look for associated defects such as nephrocalcinosis, Fanconi syndrome, and type IV RTA indicators. These clues can guide the diagnostic process and inform treatment strategies. Additional functional studies like bicarbonate and ammonium chloride loading tests can help confirm RTA diagnosis and assess the completeness of distal tubular function. Section 5. Therapeutics. Treatment of RTA focuses on correcting metabolic acidosis, managing electrolyte imbalances, preventing nephrocalcinosis, and supporting growth and bone health. The treatment approach for RTA includes correcting metabolic acidosis, electrolyte abnormalities, and preventing nephrocalcinosis. Improving growth and bone health is also essential. Correction of metabolic acidosis involves oral alkali therapy. Sodium bicarbonate, sodium citrate, and potassium citrate are used, with dosing tailored to the type of RTA and patient needs. Electrolyte abnormalities such as hypokalemia and hypophosphatemia are corrected with potassium citrate and oral phosphate. Vitamin D supplementation is crucial for children with rickets. Preventing nephrocalcinosis involves early diagnosis and correction of acidosis. Potassium citrate and thiazide diuretics help manage hypocalciuria and hypercalciuria, respectively. Treatment of hyperkalemia and RTA includes restricting potassium intake, correcting acidosis, and using medications like oral furosemide, cation exchange resins, and fludrocortisone. Section 6. References. This section provides a comprehensive list of sources and literature that support the information presented in this educational material on renal tubular acidosis. The references include key studies and reviews on renal tubular acidosis, offering insights into its pathophysiology, diagnosis, and treatment. These sources are essential for further reading.